Thank you so much for the warm introduction, and I appreciate being invited to come and present to you this evening, this afternoon, this morning, wherever you may be. Hello. So what I want to talk about today, and hopefully we'll have some time here at the end for some discussion, because I'd love to hear from you, is really talking about our work in implementing systems and approaches to surveillance, population level surveillance, over the last couple of decades at Regenstrief, and then sort of thinking about how those could be applied in other settings. As John mentioned in my introduction, I wear multiple hats. So currently, I'm the director of our Center for Biomedical Informatics, which I'll talk about in a moment, and lead our public health portfolio. But in addition to that, I also have a faculty appointment at the School of Public Health here at IU and a part-time appointment at the VA where I do informatics research on population systems within the Veterans Healthcare Administration. Just a disclosure, but also sort of a note that a lot of what I'll be talking about today, I've tried to encapsulate in this book that we published, second edition, a couple years back. This book is about all about health information exchange, and it features several examples from around the world, including Taiwan. So there's representations from all parts of the globe there, and would call your attention to it if you're interested in learning more about a lot of the stuff that I'll be talking about. The Regenstrief Institute, for those of you who are not familiar with our organization, does many things. So I think many people around the world think of Regenstrief and they think of LOINC, the LOINC data standard. We are the home of the LOINC data standard, and keep that, maintain that, hold all of the LOINC meetings and facilitate development and translation of that standard into different languages, I should say, around the world. And many people think of us as that, and that is part of our identity at Regenstrief. We work very closely with HL7 and other standards organizations to not just to promote the LOINC standard and see it be adopted, but also to advance sort of all standards and interoperability around the globe. So deeply involved with a lot of efforts with SNOMED, with HL7, with FHIR, as I'll talk about some of the work we've done locally with FHIR, but quite a bit of work internationally as well. I direct our Center for Biomedical Informatics, which focuses on research and development of new approaches, which we'll talk about today. We offer implementation services. We help others implement systems into practice. We also offer education and training around biomedical informatics, public health informatics, global health informatics, et cetera. Standards and interoperability, of course. And then Regenstrief also has a division that focuses on data services. We act as an honest data broker for our statewide health information exchange, which I'll talk about today, where we provide data for research, for public health, for other use cases. We also operate privacy-preserving record linkage services, or PPRL services, for national efforts like the NC3, which is a national research network that's got started during COVID and now is much broader than that in the US. And then we also offer technical development services. So we have engineers and other technical folks who develop applications in dentistry and medicine and other areas. The Center for Biomedical Informatics, as I mentioned, is the unit that I'm most closely familiar with and associated with, and we do work in all these different verticals. So I'll be talking a lot today about public health or population level work, but we also have work in the other areas like dental health informatics, global health informatics, et cetera. So what I'll talk about is I'll introduce the concept of the Data Modernization Initiative, which is a national initiative here in the US. I'll talk about what its goals are, and then how our work at Regenstrief has really been quite aligned with the concept of DMI for quite some time, and some of the work that we've done. And then we can talk about how maybe that could be applied, because I think the concepts that are embedded in the DMI are not just a US centric thing. They're notions that I think every country is working on with its digital health strategy. It's the work that everyone wants to see happen. So we'll get into some of the details of that, but we'll talk about how we've been supporting things like streamlining access to population level data, facilitating open data and the development of global goods, and then we can talk about how that might translate into where you're at. So let's just start with public health data modernization as a concept. There's a lot of information and details on the US CDC's website that talks about what CDC is aiming to do. This initiative dates back actually to 2019, so it started before the global pandemic, and really was trying to focus on getting resources from Congress to modernize the systems that are in not only the federal level, but also the state level and the local or regional level of public health system in the US, in order to update outdated technology, but really around streamlining data. So the goal of the DMI initiative is really to get better, faster, actionable insights for decision making at all levels of public health, right? From data. We know that it starts with the data, but it needs to be transformed into information and knowledge. And so really the kinds of systems, the kind of approaches, algorithms that we want to develop are designed to take us from being a reactive public health system to a proactive or predictive public health system, taking us from simply counting cases of disease and analyzing that in the rear, like years after it's happened, to understanding what's happening in the community right now, excuse me, so that we can respond to it. Moving away from slow reaction to being able to move quickly and analyze information quickly about an emerging concept, and make decisions and react more proactively or faster. So again, I think these are the same kinds of things that many countries around the world are working to do in implementing health information systems and then connecting them together using interoperability. The core goals of CDC's public health data strategy are these four things: strengthen core public health data, accelerate access to analytic and automated solutions, visualize and share insights to inform public health action, and advance more open and interoperable public health data. So I'm going to talk about these four goals and some of the work that we've done that fits into each of the categories to show how our work is aligned with this national strategy in the US. But again, I think if you look at these goals, the overall goal of DMI, you'll see a lot of similarity probably with the work that you're doing wherever you might be. So first, let's talk about improving core public health data. So this concept really gets at we know that there's a lot of data that health information systems, other information systems that might be used at a Ministry of Health are collecting all the time. How can we improve not only the collection of those data, but also improve the quality of that information? So our story here in Indiana really starts with our partner, which is the Indiana Network for Patient Care, or Indiana Health Information Exchange. AeHIN, the organization, is really the front office for the INPC, which is the kind of repository and health information network. AeHIN, the organization, works with the providers to connect them, facilitate sort of the interfaces and a lot of the technical operations to bring data into the platform, enable exchange for clinical purposes. At this juncture, we have well over 120 facilities, hospitals that are connected. That represents 38 distinct health systems. So, as many of you know, in the US, our healthcare system is very privatized, and so we have lots of different private healthcare systems. Our goal at AeHIN and the Indiana Network for Patient Care is to connect all of them together. So we have a number of practices, a number of physicians that are on the platform using the information for clinical care, for treatment and operations on a daily basis. Our goal at Regenstrief was really to think about if we think about the health information network then as our health information system of interest, and we want to develop or innovate on top of that, what could we do, particularly around improving this concept of disease reporting? So we know that a core function of public health is to surveil infectious diseases and other diseases too. But if we use the concept of, whether it's COVID or influenza or any other, we have measles outbreak right now in the US, whatever the infectious disease might be, we know that when there are new cases, they need to be reported to public health or to the ministry. And we need a way to report that both within the state. So in the US, we organize it so that there is a state health department that's responsible for the health of the citizens in that particular state. But then, CDC looks at monitoring health across the nation. So we need a good way to get information in the hands of the state people, because they're the ones that are usually making decisions around policy and response to outbreaks in coordination with CDC. But then they then report data up to CDC. So our goal in Indiana is to get it to the state health authority, and then they will pass it on from there. So we think about using the HIE as a utility to move that data to the state health department. So what we decided is that there's multiple pieces to public health reporting. So in the center of this diagram, you see 3 boxes that have HIE as the label. The one on the left stands for notifiable condition detection. So that's where we would have a module within the HIE that would detect that there's a new disease, a new case of a disease. The middle box would generate a form that physicians are supposed to fill out, because our laws are such that physicians have to report information to the health department. We want to try to automate that and support electronic delivery of that information. And then the third HIE box stands for Docs, which I'll talk about, but that's a platform that physicians use to receive information and take action on it. And so the forms that we generate could be delivered using that part of the HIE directly to the clinicians. The goal would be to detect a new case using laboratory data, generate the forms, provide that to the physician, have them complete that report, and make sure it gets to public health, ideally efficiently and electronically. So for this project, we used the Docs service, which is part of the IMPC. What we did was we pre-populated the communicable disease reporting form. It would show up in the inbox of the physician, just like they get radiology reports or the actual laboratory report, et cetera. It would show up in their workflow. So we wanted to support existing clinical workflow. Have that form show up there with most of the information on it, or at least as much of the information as we could glean from the HIE. And then this allows the physician to review it and kind of approve it essentially, so it can move forward. And this could be done by the nurse in the clinic. It doesn't have to be by a physician, but run it by someone within the clinic to sign off on it and report it to public health. The conditions of interest in our particular study were several sexually transmitted infections, some zoonotic diseases, and then hepatitis B and C. We picked these for the project for a variety of reasons. We wanted different types of of diseases, some that would have numeric results, some that would have sort of short answer results like reactive, for example, in a titer, and then some that would be more open text, like clinical notes, if you will, from the lab. Often there's a culture done, for example, for salmonella, where they're testing for multiple diseases, and what you get back is a large blob of text that says, this was negative, this was positive, and so it's all kind of jumbled together within a single sort of HL7 message. So the methods that we used for the study, we used a controlled before-after trial. Randomization was not possible in public health. Sometimes it's very hard to do in health information system research is to do randomization. But what we did do was we took the pool of clinics that were already connected to the HIE. We reached out, got a subset of them to volunteer to try this out, and then we looked at their reporting within that clinic before they implemented the HIE-based solution, and then versus after they implemented the HIE solution, and we compared that to the similar clinics in the network that did not use the volunteer to do the intervention at all. Our primary outcome measure was a change in the rate of reporting pre and post intervention, but we also wanted to look at whether this solution would improve both completeness and timeliness of the data. So I talked about wanting to make a difference on the quality of the data, not just facilitate electronic exchange. So this is our primary outcome. You can see that in the intervention clinics, the proportion of cases that actually got reported to public health went up significantly after the intervention. The base rate, though, was higher than in the control clinics, which probably didn't surprise us, because if they were willing to volunteer to do this, then they probably had some interest in it. But that change was much greater than sort of the actual, what we saw was a decline in the control clinics. So those clinics who didn't participate, their general percentage went down over time. We also broke it out by looking at each quarter, the reporting rate by clinic, and you can see that in the middle of this graph, the gray line that goes down, that's when the intervention was introduced into the system. And so you can see reporting rates before the intervention were generally similar between the control clinics in the blue line and the pilot clinics, which were in the red line, generally the same. Yes, the pilot clinics rate was a little higher, but the pattern was the same. So we would call that parallel trends were happening before the intervention. After the intervention, though, it's very clear that there's a distinction between the pilot sites and the intervention sites. With respect to completeness of data, 4 of the 15 fields needed by public health improved significantly. Interestingly, it was the fields around the physician's name and address. Apparently, before the clinics would send information in and not put that information, they just assumed that since they were mailing it from the clinic or faxing it from the clinic, that the health department would know who the provider was. 9 of the 11 remaining fields improved, but not significantly. But there was still some improvement there with respect to completeness of information. And then, of course, patient first and last name didn't change. It had always been 100%. In terms of timeliness, we did not see a dramatic improvement between intervention clinics and control clinics. Timeliness overall, improved, going from 11 days in the control clinics to about 8 days, and about 10 days to, well, just above 10 days to just under 10 days for intervention clinics. So we really didn't see an improvement in terms of time to get the information to public health, but certainly we were encouraged by the other results. This is just an acknowledgement of our study team, involved many people here, including our local health department for which the information was reported, and our work was funded by the Agency for Healthcare Research and Quality, as well as the Robert Wood Johnson Foundation. So that's our first one of our initial projects to improve both delivery of information and quality of information, for improving sort of core functions of public health. The next project is accelerating access to analytic and automated solutions to support public health investigations. And for this, I wanted to talk about our more recent work, which has been around chronic disease. So I think this is of high interest across the world, as most countries recognize really the main things that are now killing people are becoming less and less infectious disease, more and more chronic disease. There's still a need for surveillance of both, but we need to put more emphasis on chronic disease as we move forward, and how we can use health information systems to support that. The project acronym that we're part of here in the U.S. is called MENDS, MENDS, which stands for Multi-State EHR-Based Network for Disease Surveillance. It involves multiple sites around the U.S. So here we are part of a collective. So we're focused on our health information system in Indiana, but we partner with these other organizations across the U.S. to achieve the overall aims of the MINS network. Briefly, how the data flow is that it starts with data being captured in the health information systems that are being used in our clinics and hospitals. That then gets reported to our health information exchange, where we integrate the data. We then build on top of that a population management system or population health information system. In this case, it's called PopMedNet, which sits on top of it, which looks at sort of de-identified case information for hypertension, diabetes, obesity, etc. Then, once we have aggregate level data, those get reported up to a platform that CDC sponsored called Riskscape. It's just a visualization tool. So, I mean, the tool is probably not as important as sort of the concept of how information flows through the system. But Riskscape, there's lots of visualization tools that exist out there. The goal is that public health wants to look at that aggregate level data for their work, and they don't need to know all the details around who the patient is, because they're not going to necessarily be involved in the care of those patients. Moving data through the system allows us to create population level reports. So here's an example of estimated hypertension in Indiana by overall, by sex, by age group, by race. Allows us to look at trends and patterns in the information, so that public health can better understand who's getting this chronic disease, or who's living, I should say, with this chronic disease in the community. We also have the ability then to look at it geographically, because we have patient address information in the health information system, so we can look at by county, as in addition to the statewide data, so we can see where those clusters are of prevalence, high prevalence of hypertension around the state. Similarly, within a county, we can break things down. So this graph is of the Indianapolis area by zip code, and it allows us to look at patterns of hypertension prevalence, which ranges from 30 to 60%. So this allows our public health partner, for example, to sort of say, where should I be putting screening programs or prevention programs in the community, because I have limited resources and I can't be everywhere all at the same time. Similarly, in addition to just prevalence, we're also looking at hypertension control, because that's different. There may be a section of the community that has high prevalence, but if if they're engaged in clinical care and they're getting managed for that disease, then that may be a part of the community that may not need as much attention from public health as, say, this you know a section of the county where there might be moderate prevalence but very limited control of the disease, and that would be an opportunity for secondary prevention activities. All right, so the next, so that's a little bit about how we're trying to support both analytics capability and reporting in chronic disease. The next area, next goal of DMI is to visualize and share data insights to inform public health action. So here's where we've been doing a lot of work on developing both visualization tools or applying visualization tools in on top of our health information exchange platform to support the work that our public health organizations want to do. This is a dashboard that looks at the difference between COVID-like illness and influenza-like illness. At the beginning of the pandemic, those lines were there wasn't much distinction. Everything just looked like ILI. And then we worked with our health department partners to have a better definition for CLI so that they could track it and distinguish it over time. And again, look at it broken down by sex, race, ethnicity, age, etc. Similarly, we put together a community level dashboard to track hospitalization events and clinical impact of COVID on our health system. So we developed this. This is by applying sort of Tableau, which is a different information visualization tool to support the public health or population level data, so we could look at data again statewide or by within a county. More recently, we've begun to apply these tools to sickle cell disease as well, which is a chronic disease that historically has not gotten as much attention in the US. And now the Health and Human Services is putting more emphasis on this. So we partnered with our state health department and our major clinical providers for sickle cell care to develop a similar dashboard. This time around, though, we're not using Tableau, we're using R, and we're using R Shiny in order to develop something that's built more on an open source tool that allows us to do the same kinds of things, to visualize the data at the population level, looking at, prevalence rates per 100,000 population, breaking it down by age group, and looking at prevalence trends over time, and both, again, at the state level or within a particular county. And also here, clinicians were interested in comorbidities associated with SCD, so that was another feature that we added to this particular tool as well. All right, so the last goal of the public health or the data modernization initiative is to advance more open and interoperable public health data. So many of you on this call might be familiar with this image, which is what we call the OpenHIE framework. That's work that our team has been heavily engaged in for the last decade plus. And so I'll talk a little bit about that, but that's an example of one of the products that we're trying to make sure is out and available, a global good across the world. A project that our team has also been working on is called, which is called Cumulus, is partnered with Boston Children's Hospital, as well as the CDC Foundation. And what we wanted to do in this particular project was take bulk fire and implement it in such a way that it could be used to move data more effectively to public health. So take an open standard, build it on top of an open source platform. So in this case, the data start at the EHR, they come out of the EHR using bulk fire, and then they are de-identified and reported up to the Cumulus platform, which is an open source platform where you can build tools and other things. It's part of the Smart on Fire kind of suite of applications. And that tool also has various visualization capabilities within it. So you could take a more plug and play type application in this case for visualization and use it, connect it, if you will, through bulk fire to access the data from at the population level. So in our context, essentially, we take our health information exchange and we implement our bulk fire client on top of that HIE foundation. So we already had a individual fire, if you will, server implemented for patient resources and other resources at the individual level. The smart bulk fire client we implemented to pull data out at the population level. That then allows us to push those measures to Cumulus, and then our partners at the Marion County Public Health Department could access that for surveillance. We began piloting this at the end of 2022. There were multiple sites. We were one of several sites that did this. And throughout the process, we created and validated computable case definitions for a couple of diseases that were of interest to the CDC Foundation. We tested those and validated them, found some challenges with the fire spec, which we've fed back to the HL7 team. They've implemented those now into the updated specs that are out for release now. And if you're interested, there are a couple publications that we have out in that are available. They're not behind paywalls that are out there. And these publications actually, by the way, were referenced by the Assistant Secretary for Technology and Policy, ASTP, at the federal level when they were creating their specifications around requiring hospitals to implement bulk fire. Okay, next I wanted to briefly mention Open Health Information Exchange, which is another project that we've been working on to build communities of practice around interoperability. So I mentioned that we have this this architectural framework that the community has developed, and there's multiple components to it to sort of say, if you are thinking about interoperability at the national level, what are the components that go into that? How can you connect them together to support things like population health? So a lot of the technologies that I mentioned that we've built in Indiana fit well within this concept of an HMIS, or Health Management Information System. Of course, and we leverage our terminology service and our client registry, which is our health information exchange platform, et cetera, in order to make everything work. But the idea is that this framework allows you to think about the components and how they fit together to enable use cases like the ones I've talked about. I also mentioned that Regenstrief is the home of the LOINC data standard. This is another global good that we are passionate about, and so it's our goal to continue to make that available and work with countries who are implementing data standards and interoperability to support their efforts at building and achieving the goals of their digital health strategies. So again, that's also another critical, I think, component of what Regenstrief does in the broader global community. And so I'll put a plug in for the LOINC conference, which is later this year in Montreal, Canada. All right, so those are some of the things that I wanted to talk about. I think now we have some time. I'd love to hear from you about how we could take some of the concepts, or maybe how what I talked about in my presentation might be related to what you may be doing in your country or in your institution to advance population health or surveillance of diseases, whether that be infectious or chronic. So, and again, thank you very much for inviting me to present today.
Yes, thank you for sharing your work at the Regenstrief Institute on Surveillance through Health Informatics, Dr. Brian. So I'd like to inform our participants that we have already opened the microphones in case you'd like to share your thoughts or ask questions to our speaker.
Hey, hello everyone. Thank you, Bran, for an excellent presentation. Since I little bit enter a little bit late, but still the presentation is very excellent. I found it very interesting. So my first question is that you shown one of the graph that in the pilot and difference between pilot and the control clinic. So in the last quarter, it seems very significantly jump the performance, or you can say. So what was the factors basically? It seems like it is not only one factor or two factor. There are so many things, just it contributed this impact. So
Yeah, you're
this is
talking about the jump in the control clinics, you mean?
yeah, control and the pilot. So in the last like few quarter is so dramatic, the uptrend is so difference, the difference is very significant. So that was my it's just wondering.
Yes. Yeah, that was actually that was largely it's a great so thank you for that question. Agree. Like there is a jump there. And that actually had to do with an outbreak that was happening in the county. So when the outbreak was happening, the health department was pushing information out to clinics about an outbreak of a sexually transmitted infection in our community and the need to report the data, giving clinicians resources on how to order testing or how to order treatment or how to refer patients to the health department for free treatment. So there was a lot of communication in that last couple quarters around that particular outbreak. So yes, that kind of communication blitz or outbreak situation did cause the whole community, both control and pilot, to be more aware of those STIs, which were part of the data we were monitoring in our program. So
Pilot was so the pilot was so high compared to the control clinic. That was my one of the
right, exactly. Yeah, so I think, and again, I think if we would carry the data forward, we would see after that outbreak, the control clinics would probably have gone back down, and there might have been even a little less emphasis in
But
the
do you have that
pilot.
data after the
We don't because in order to collect, yeah, so one of the challenges was in order to collect data comprehensively, we had to go to the health department and get their data on everything that came to them by mail, fax, electronically, so we could understand holistically all the cases that they were getting in order to do that. And of course, that's time consuming. So we really have data for that period before our intervention and then the period after. But I mean, the health department, of course, has that data, right? So we could go back and get that, but it's not something that we've done. Yeah.
Okay. My second question is that as we know that we have several types of surveillance, like active surveillance, passive surveillance, then sentinel surveillance, then syndromic surveillance. As far I see in your presentation, you mentioned the syndromic uh, surveillance, but normally in general in your state, which type of surveillance you mostly I mean follow?
Yeah, so great question. Yeah, so I mean, we still use. I don't think that. So a lot of the EHR solutions that we have are kind of driving us more towards passive surveillance, right? But I think that it doesn't replace sentinel surveillance at all. We still use sentinel surveillance particularly mainly for infectious disease in our state. So we still have infection preventionists and clinicians that are doing sentinel surveillance, and we have I think it's monthly phone calls with them to review what's happening. So we still support that sentinel surveillance that's happening. Of course, we support syndromic and passive. I would say that there's probably there's not as much active surveillance, right, as
Okay.
in our state. It's a lot of passive as well as syndromic, but there is no real replacement for sentinel surveillance.
Thank you. Thank you very much. Thank you for your presentation. It was really good.
Yep. Thank you. There was a comment about one of the papers, and I wanted to address that. So you're right. Our paper does appear to be firewall. I will talk to our it should be in PubMed Central. So I'll talk to our collaborators at BCH and see if we can't speed up getting that open access. So I apologize for that.
Yes, thank you, Dr. Brian. We can share the information as well later on. I think there are no new questions yet, but maybe if you have questions for our speaker, we can send them for you after the session. I think since there are no new comments or questions, we can wrap up the session here. Once again, on behalf of AeHIN, thank you very much, Dr. Brian, for making the time to share your work at the Regenstrief Institute with the AeHIN community.
Of course, anytime.
Sorry, I have just one question I need to ask you.
You're
That
fine.
you mentioned that there is a conference on October, I think.
Yes.
Is it possible to participate from online? Registration is open for.
That's a good question. Let me ask. I don't know if that's possible or not, but I will ask the Loink team that question and get back to you. So shoot me an email. I think I put my email up there, or here I can put it in the chat too.
Yeah, you can send in the chat.
Yeah, and then send me an email. I will circle back with the Loink team and get you an answer to that question as to whether they're going to support virtual participation.
Okay, thank you, Brian.
Yeah, of course.
Yes, Dr. Brian, sorry, I think we have a new question from Dr. Daniel Lead. It's asking, do you have current collaborations with WHO or PAHO?
I think the general answer is yes. I think that our and I see Shelby's on the call. Our Open HIE team has active collaborations there. I also know Carl Leitner quite well. Carl is now at the WHO. So the short answer is yes, we're kind of engaged around some activities like the international patient summary work that HL7 is sponsoring. And so we're kind of engaged in a couple of things there. In the past, we were a formal collaborating center of WHO. I think that's something that we would very much welcome in the future as well. So, but we don't, I would say right now we don't have as many collaborations as what we've had with them in the past. But yes, we do have some collaboration with WHO and to a lesser extent, PAHO.
Yes, thank you, Dr. Brian and Dr. Daniel. Thank you, everyone. Thank you, Dr. Brian.
Thank you all. Have a great rest of your evening or day.